So we also know that progestins, often given to protect the endometrium in the uterus, are associated with slowing of brain function, including brain metabolism, and in some animal models, irritability. This is harder to track in humans, but there are some data on that as well. So people are always wondering, what should we do? And just as a way of disclosure, I was a co-investigator for the Women's Health Initiative, which was that gigantic study that we did for 15 years, in which we had two groups that were given two kinds of hormones, estrogen alone or estrogens plus progestins, but it was a very specific study design. And it came out basically with a lot of hullabaloo, and people took years to put it into perspective. So during that time, we tried to refine why people should take hormones. And so the first thing was symptom relief. The next was disease prevention. The third was disease treatment. Anti-aging, that's more ephemeral and hard to get at. And then health promotion. So if you took it from the first to the last, you could see that the last two are a little hard to prove. But this is the actual summary of the Women's Health Initiative. So it took them about 15 years to kind of verify the data, analyze it, and look at it. And just to put it in perspective, everything in the top panel is when women were given a single dose of conjugated equine estrogens, Premarin, plus a progestin, medroxyprogesterone acetate, in a fixed dose regardless of their body weight and regardless of any of the conditions that they had. And the hypothesis at the time when it was initiated in the early 90s was that the sicker you were, the faster you would benefit. So they enrolled the oldest women first, and then came back to the group 50 to 60, which is the more normative group for giving hormones. And then the bottom panel is the women that had already had a hysterectomy and were eligible for conjugated equine estrogens alone, so Premarin alone. Same dose in Premarin in both arms, and then the top group had progestins. So I've tried to make this easy to see. CVD is cardiovascular disease, stroke, deep venous thrombosis, breast cancer is BC, colon cancer, all cancer, fractures, mortality, and diabetes mellitus. So anything in blue is a reduction. Anything in red is an increase. So if you look at the top panel, given conjugated equine estrogens plus Provera or medroxyprogesterone acetate, there were three things that were slightly increased. What's hard to read is the y-axis, and it's how many events occurred or would occur if, I can't even see it myself, well, if 1,000 women took this drug, this combined product, for 5 years. So the number of women years is very high, and the number of events is very low. So the increase is more in the order of 1 to 5 events for 5,000 women years. Not so very much of an increase. If you look at the benefits, they're actually bigger than the risks, even when you add them up and say what's the overall risk benefit. And mortality is actually improved, decreased. If you look at the bottom panel, estrogen alone, this is an oral estrogen. There's only one thing that's an increase, and it's really minor. It's two more events if 5,000 women took this for a long time, or 5,000 women years. But what is in the very far panel is diabetes. Both of these products, given in a one-size-fits-all without any individualization, remarkably decrease the risk of diabetes. And as we know, that's one of our major threats. It's one of our major things that we deal with all the time, because estrogen is an insulin sensitizer. And I think that good news that came out of this study has really been lost. You can also see that fractures are prevented in both groups, and all cancers. So a lot was made of the first part about the increased risk, but you can see overall, regardless if you take just even the combined product or the estrogen alone, there's a lot of benefit. So this led a lot of us to say, okay, it took us 15 years of data analysis. This was a New England Journal short editorial that came out in 2016 or 16. So 15 years after the study ended. And we're just trying to help people understand what we learned and where to go from there. And this study did not discretely focus on the brain. So now I'd like to kind of shift with that as the background and talk a little bit about the brain as one of the target tissues that wasn't studied and was left off of this important study. So the thing I'd like to leave you with tonight is that not all estrogens are the same. Now, if you had 3 years to spend, I'd try to teach you all the little details about why all estrogens are not the same. But if you will just bear with me for a few minutes, I'll try to say a few words about which estrogens might be better. Not all progestins are the same. There's a lot of molecular biology that came out in the 1990s and the early 2000s that helped us understand how even minor tweaks in steroid backbones have major effects. So I'm not going to go through all that today because I think that would kill all of us. We'd all be dead from hormones for a different reason because this is too much detail at this time of day. But the other thing no one ever argues with me about is that not all women are the same. So if you would like to have that discussion later, I'm up for it anytime. But I never have any trouble in my office with that concept, that women really feel like they need individualization. The other thing I'd like to have you understand is that hormones are active at the picogram quantity, 10 to the minus 12th. They're very potent. So it really matters to get it right. Can you imagine giving insulin in one size to all diabetics? Like, what do you think would happen? We'd probably undertreat half and overtreat the other half, right? We'd have a mess. So we haven't really actually invested the energy yet to figure out what the best way is to individualize hormones for postmenopausal use. So there's still a lot of work to do. So this is my trying to capsulize this. Estradiol is there, stress is there, cortisol is there, thyroxine is there, insulin is there, calories are there. You don't want too few and you don't want too many. We got to get it right to have the best impact. So what is the best impact going to be? We often go, like with diabetes, to wanting to have a blood sugar that's physiologic. So to do that for estrogen, we have to think, what is the estrogen that our own ovaries make? And that's estradiol. So sometimes we just collapse across that category and forget to say the right word. The right word is estradiol. And it has the best effect on tissues because it's what Mother Nature makes from the ovaries, and it circulates in a given amount. And if you were to average it in a 25-year-old across the menstrual cycle, it's 100. I'm rounding it to something I think you can remember. So 100 picogram of estradiol is a physiologic level. So what about using estradiol for postmenopausal hormone use? So just by way of acknowledgement, this idea came to us when we were doing in vitro fertilization. So we never used anything other than estradiol for fertility. We were afraid that Premarin wouldn't give the right results. So if it wouldn't give the right results for our infertile patients, why would we be giving it to our older patients? That doesn't actually make a whole lot of sense, right? Why not use what's best? So now we've been sort of wandering the investigative realms looking for what matters the most. Is it the age of the patient, the estrogen type, the route of administration, the timing of initiation, and the duration of exposure? And the answer to each of those is yes. All those things matter. So I'm not going to browbeat you with this, but not all women are the same. But the ovary is remarkably constant in reproductive life. So the amount of estradiol that would be physiologic is the same for every woman. And what do we think estrogen is doing? It's kind of teeter-tottering between what we call senescent syndromes, aging, and maintaining cellular repair, growth, mitosis, and we don't want to have so much that we cause oncogenesis. So we have to balance these two to come up with something that is actually going to keep us healthier as we age. I'm an obstetrician by training, And when I came of age as an obstetrician, people had this idea that babies could deliver themselves. Now, if you would like to follow any obstetrician around for a day or two, you will shortly realize that most babies do not deliver themselves and that we need to intervene. So then the argument about using hormones was, well, you know, it was meant to be. Well, if meant to be, we'd lose 1 in 7 women in childbirth. So we're past that it was meant to be and trying to harness science to do some good. So how can we do this? Well, we can go to the scientists. So Elizabeth Blackburn and her colleagues won the Nobel Prize for telomeres just a few years ago. And what did Elizabeth Blackburn do after that? She started to understand what estradiol would do to telomeres. It's a good question, right? And who would you want doing it more than Elizabeth Blackburn, who just won a Nobel Prize for discovering telomerase and telomeres, the parts of the chromosomes that control aging. So the longer your cap, the longer your telomere, the slower your age, the more your cells replicate faithfully and don't make mistakes. So lo and behold, what she has found in the brain is that estradiol actually keeps the brain younger, as evidenced by longer telomeres. I'm not going to go through all that data because it really is. But I show you all the details because I want you to know, if I just put the little summary up there, you might wonder, where did that data come from? But there really is data for all of this. I just have to make it short tonight. So how do hormones work? Here's just a short list. And, you know, by way of acknowledgement, my husband is a molecular endocrinologist, and he's sitting right over at the other table. So I have to be honest tonight, because otherwise I'm going to go home and I'm going to get told I did it maybe not quite right. So, and because he's very precise, I want you to understand that hormones act by a really pleiotropic number of mechanisms, all of which are probably important. And when we think about the brain, it's not one tissue, right? It's got all sorts of little nuclei and tracts and connections. And so we often think of the brain as sort of a mystery organ, but we need to demystify it and understand all of the things hormones do. So they control affect and cognition, motor coordination, neuroprotection, neuronal excitability, for instance, seizures, and pain thresholds. And this is one of my favorites, hearing thresholds. So if you give oral contraceptives to women, they really do hear less well. Thank you for laughing. So you think about that one. Men don't hear low-level ambient noise the way women do. And if you are, as a woman, tired of hearing all that low-level ambient noise, just need to take some hormones that are, because the progestins and birth control pills are actually partial androgens. And you, too, don't have to hear all that ambient noise. So I sort of introduced the idea that hormones need to be titrated. And it's really easy to think about that with thyroid, right? We spend a huge amount of time trying to get the dose right. And why? Because patients complain if you do not do it right. And so it's just better to try. So we have developed strategies. So this is a wonderful study looking at the brain off of hormones. And what they found, and these were thyroid cancer survivors who need to come off and get some studies done to look for metastases. So they found that coming off thyroid decreased cerebral blood flow by almost a quarter, and that the patients all became irritable, anxious, and depressed. I don't know that they tracked the number of office visits to the doctor, but I assume they weren't really happy. And what was really remarkable, and it's a little hard to appreciate on the slides, but to see the little colored areas, those were the areas in the brain that were impacted. So not very big areas, but they had really big effects. And if you got the thyroid right, the brain was happy, and those areas functioned better. So what about for hormones like estradiol? So somebody did a similar study. They had half of the women stop what they were doing for hormones. So this is an observational-like trial in the early 2000s after the Women's Health Initiative broke and there was a lot of panic. So they said, who wants to volunteer to stop their hormones, and we're going to study your brain using neuroimaging 2 years later, or you can stay on your hormones and we'll actually neuroimage your brain. And it was randomized. So I want you to notice the colored areas again. And then the little areas I've highlighted in red. So estradiol users were 3 times more metabolically active in key brain areas that subserve cognition and emotion than those that used any other kind of estrogen. So remember, I introduced that little idea that not all estrogens are the same. This is some data showing that actually not all estrogens are the same. And they did do psychometric testing, they did reading tests and things like that. So not only was this evident on neuroimaging, there's evidence in terms of performance as well. This is a pretty big study. There's a couple different sub-studies within it, and the references are provided. So what do you think about all this? I mean, there's a huge amount of information, and we're trying to synthesize it and put it all together. And each of these kinds of information is really important. And let's just talk about what kind of information is hard to come by. So a key criteria for a randomized clinical trial is that you can measure the endpoint within 3 years of initiating whatever it is that you're going to study. Imagine trying to study estradiol 3 years after you initiated it and looking at like neurodegenerative disorders. You won't be able to do it. So we have to look at other ways of getting the answer. And so some of what I've been presenting are other ways of thinking about this. So let me show you what we've learned. So this is a really important part of the body called a synapse. And it controls how neurons talk to each other. And when you lose about 25% of these connections, you develop something clinically that we call mild cognitive impairment. In other words, you're not so sharp. Mental fog, cognitive fog, you don't feel right. It's not a good feeling. And I have a lot of people in my office at the time of menopause who come in saying, I just don't feel like I used to feel. I'd like to feel better. It's a soft complaint. It's not like any one thing is bothering them. They can't remember words as well. They just don't feel good. So a lot of times we used to just say, you're just getting older, live with it. This is usually not a good thing to say if someone's in an irritable state, but it's never a good thing to say, really, right? Nobody wants to be told that there's nothing that can be done. So people said, let's design a study using a primate brain, because we're not going to be able to do this one in humans, and it's looking at young and old monkeys on and off estrogen for 3 months. And I'm going to just tell you, the black dots are synapses. Brain A is off hormones for 3 months. Brain B is on hormones for 3 months. And the black dots are synapses. Which brain would you prefer? A or B? How many want B? No. So A is the brain that is going to be slow. B is going to be the brain that thinks faster and can participate in more things more energetically. And so it's just a little idea that estrogens support synapses. Before anyone in the audience gets jealous, I'm going to give away one of the punchlines now. Who has higher estradiol levels at age 25, men or women? The door prize is, I don't know yet. So the trick answer is they have the same. Okay, so fast forward 25 years, who has higher estradiol levels at 50? Men or women? Men. So let's resume. This is, on one side, a brain that is depressed, and on the other side, a brain that is working fairly well. And the bright areas that are lit up are serotonergic binding in those brain parts. So we did this fun study using neuroimaging and looking at the brain on and off hormones of 50-year-old women who were postmenopausal and had been taking no hormones for at least 3 months, and you've probably caught my drift by now. Their estradiol level was replaced transdermally to approximate physiology, which we took to be 80 picogram per ml, because remember, 100 is physiologic for 25-year-olds. So the baseline positron emission tomography, looking at serotonergic binding, and remember what that has to do with depression, is the first one. The MRI on the other side is what's called a region of interest. So those little green things are around two areas that we wanted to study. The first, the lateral ones, are the dorsolateral prefrontal cortex. That is your mistake center. Mine right now is working overtime in case I say the wrong word. It's like monitoring everything I do, and it's really annoyed. And then the other one, those little walnut shaped in the middle, is the anterior cingulate cortex. That is your emotional intelligence center. Now imagine a person who didn't have that and how far they'd get in the world. So then look at those two centers, off hormones for 3 months or more, and then back on hormones. And it's serotonergic binding in those areas. There's a dramatic improvement. So in some ways, at the time of menopause, women lose their natural antidepressant. And by giving estradiol back, we can restore it, their serotonergic binding. This is a study done in monkeys because it's too hard to do any other way. But it's giving monkeys hormones, they don't know what they've been given, and looking at their sexual behavior and their friendliness. And it's first with males, and then the second with other female monkeys. Now, for those of you who don't know much about monkeys, female monkeys can be very, very irritable to other female monkeys. If you put 4 male monkeys in a cage or 4 female monkeys in a cage, which cage will have the highest mortality, would you guess? Thank you for laughing. It's the female cage. So it's an important thing to study, right? If you're a monkey, you want to know what will keep you happy. And if it's hard to see this, but at the bottom, these are monkeys that are oophorectomized, and they're given back estradiol only, or estradiol plus natural progesterone, or estradiol plus Provera. This was the progestin included in the Women's Health Initiative. Look at the bottle panel for irritability and antagonistic behavior to other female monkeys. There's nothing better than medroxyprogesterone acetate at making monkeys mad. And that's what we studied in the Women's Health Initiative. So was that the right thing to study? Probably not. So we need to go back at some point to the drawing board and understand this a little bit better. And right now we have all sorts of kinds of estrogens. And you may know that we sometimes give an anti-estrogen for the treatment of breast cancer. So we studied that in monkeys too. And the one that we studied was tamoxifen, because it was in use at the time. And it caused the monkeys to become extremely anxious and antagonize the benefits of estradiol for mood. The other thing that antagonizes the benefits of estradiol is cortisol. Cortisol is what we make when we're stressed. So when we're stressed, estradiol doesn't have the same access to the molecular machinery needed for all the things we've been describing. So this is really molecular endocrinology. I'm only going to share with you the little panel in red. But there are many genes that are co-regulated by cortisol and estrogens, and they actually antagonize each other's actions. And this is such an important finding to understand, because actually it plays out when we actually try to give estradiol to women who are already depressed or stressed, and they don't respond in exactly the same way because their brain is not in exactly the same state. We also know, remember that first part about clotting and VTE, that estradiol is neutral when given transdermally or protective from VTE, and all of the progestins are somewhat prothrombotic, except for progesterone, Mother Nature's progestin. And you can imagine in pregnancy, there's a huge amount of progesterone. So if it caused VTE, a lot of the time, our placentas would clot off prematurely. So it doesn't. It actually causes vasodilatation. But the other progestins cause some vasoconstriction and a tendency to clotting. But the worst of those is medroxyprogesterone acetate, the one that was studied in the Women's Health Initiative. So when people tell you that we've really studied this question, you need to be a little wary. Maybe not so much. Maybe we really haven't done the right studies like we would have done if someone had diabetes or thyroid disease. We didn't do any titration. We didn't make sure people are on the safest estrogen. We didn't make sure that they were on the safest progestin. So I'm going to skip forward some of this. This is the one I want to share because it's probably people you may even know. So this was a longitudinal study done in Cache County. When I first found this study, I had no idea where Cache County was. It was like, you know, some mystery place to me. And then I moved out here. It's not a mystery place after all. But it's men and women who are free of disease at age 65 were enrolled, so they didn't have any known disease at the moment. And then it's rates of dementia followed forward. And this was in JAMA in 2002, almost exactly at the same time all the bad news was coming out about the Women's Health Initiative. And so the panel A is rates of dementia, men and women, and the open circles are women. So it's not good news, right? As women age, they look like they have higher rates of dementia. It's not just because they live longer. And then if you look at if they took hormones, so the top panel in the panel B, the top line in panel B is actually if they didn't take any hormones. The bottom group that overlaps with the men is if they took hormones for more than 10 years. It didn't even matter what hormone they took, if they took any at all. And that study has actually been going on for a long time. It's still going on. They've republished some of the data, but it's just too hard to kind of show you that. That first slide is really honestly what the finding is. So I promised you the punchline a little prematurely. This is looking at testosterone and estradiol levels in men and women in the brain, in the CSF. So you can see testosterone levels are much lower in women than they are in men, and estradiol levels are the same. So men have endogenous neuroprotection. This is a Finnish study by a good friend of mine, Tomas Makala, and it's looking at vascular dementia and all-cause dementia, showing that regardless of age of initiation, being on any estrogen actually reduced the risk of Alzheimer's disease. This is the Olmsted County prospective trial done in Minnesota, showing that if you have an oophorectomy prophylactically before age 45, you have an increased risk of death, depression, Parkinson's, and dementia. So, quick tour of my world. Estrogen therapy may be helpful for the brain. I showed you the other risks and benefits, and really the benefits outweigh the risks. So what we have learned, without going through this in any more detail than now, is that the non-oral route of estradiol is the safest. And it may, in fact, promote actually lower risk of VTE and even potentially lower risk of stroke. We haven't really figured that one out yet. But giving estrogen of any kind orally, including estradiol, might be pro-stroke. So not what we want to be doing. We have a lot of information-free zones. This is a wide open question. So it's too early. I will argue always too early to be dogmatic, but it's too early to close your mind, literally, to whether or not low-dose estradiol could be helpful for postmenopausal and perimenopausal women. And the impact of progestins, really, we need to do some work. We have a lot of work to do. So step one, when I'm in my office, find the estrogen the person will take. There are a lot of transdermal estradiol options. I'm not going to go through all of them, but this takes me quite a while. Step two, figure out if they need a progestin. One of the easiest ways in the world these days is to put in a progestin-bearing intrauterine device. So simple. And for contraception, it's now good for 8 years. In this context, the larger dose ones are good for 10 years, maybe more than 10 years. So you don't even have to worry after that. And the circulating levels are 1/10 those found in an oral contraceptive. Step 3, think about androgens, topic for another day, invite me back. And it's been my pleasure over all these years to have, one, NIH funding, to have great colleagues, and to have friends like you who are good colleagues that are trying to do the right thing for women's health. And I so appreciate your attention tonight. Thank you. Do you want questions? What's your preferred format? Oh. Yes.
So what's the difference between bioidentical versus just the ones that come packaged?
Such a great question.
And I know they're all bioidentical, but is there truly difference?
So what's different about the sort of pharmaceutical grade products like transdermal estradiol patches or transdermal estradiol gels is they are in a time release mechanism that best mimics the ovary. So where you sometimes get into issues, so estradiol itself has an extremely short half-life of less than 4 hours. So if you put it in a gel, but the gel isn't time released, you get a little burst of estradiol. It doesn't come close to mimicking physiology. It would be like giving, very short-acting insulin to a diabetic and expecting them to not have glycemic control for the rest of the day. It wouldn't work, right? So you have to have a long-acting insulin, or you have to use insulin more often. So expecting people to take estradiol in a little gel frequently enough to approximate physiology wouldn't really work. And it was a great breakthrough when the people that made Post-it notes figured out how to make estradiol in that Post-it note, and they called it a patch. And then it was no longer colored pink, blue, and red. It now is transparent, right? But it's the same glue. And Post-it notes, it's 3M. And so they learned to embed estradiol in the glue so that it was time released. And it's constant for 7 days, just about. I mean, it's sort of an amazing advance in my mind. And then there is one that is also a time release gel called Divigel. There's only one on the market right now. It has pretty much constant levels for almost 24 hours, whereas all the other ones may not. I mean, it has to be proved. But most of the time, because the dose of estradiol is low and the half-life is so short, there's just a trace of estradiol for a couple hours. And that's not going to give you the same biological or physiologic impact. Does that answer your question?
Yes, it does. And I don't mean to hesitate, but I have another question. Question is that, I used to put every day on hormones, and I did every day on hormones, and now it's about so all these women that are now, my understanding was that if you're symptomatic, go ahead and use it for perimenopausal, menopausal, the first 5 to 10 years. You're saying that we should start at any time, even if you're not symptomatic, other than maybe a little bit of, cognitive decline?
So I used to call this talk Concepts and Controversies, and you've just waded into the controversies side, but that's good. That's good. Keep wading. I mean, that's why I showed you all the information gaps. I don't want to say I know the answer. What I want to say is we should do the studies. But I don't want you to say you know the answer either until you know the answer. So you could say I remain in a state of grace with this information. And I look forward to the day when I know a little bit more, because it is the art of medicine is to take all these other kinds of studies and synthesize them and come up with what you think is today's best answer. And I can't hold you responsible for tomorrow or 2 years or 5 years from now, but based on today's information, what we do and don't have, I think it's safe to use low-level estradiol indefinitely. Makes you feel any better. I've got my 92-year-old mother on it because she was having such severe hip and joint pain she wouldn't walk. Now she walks. But I also noticed her speech is a lot faster too, and she's a little bit happier.
My understanding is that that could cause an ulceration in the stomach if you have it. That's not true, or?
So if you give transdermal estradiol at a physiologic or subphysiologic level, so the older the patient is, probably the lower the dose you want to do. So there is this little product that is almost not detectable that I use in anyone over 80 called Menistar. Sorry for the trade name, but it's only one product on the market. And the only reason I don't ever use it all the time for those who want it is that it's sometimes not covered by insurance. But if I were allowed to give it to the symptomatic patients that want it, it's good for bladder, it's good for joints. You know, I'm not even giving it to protect their brain and necessarily at that point. But if they're not walking, they're going to die. I mean, people have to move. And so I think that, I didn't even talk about that, but joint pain is one of the most common complaints that perimenopause and menopause often goes to ortho, right? We can't ask them to be giving these hormones. That's really not their area. So I've saved people a lot of surgery, really, quite honestly. I saw one of my patients here today, my former patients, who didn't have to have shoulder surgery because she actually started a low dose of estradiol, and it actually helped her enormously. So, I mean, there are other benefits other than joint pain, but, I mean, I think we haven't really captured the full extent of benefit if we just look at the WHI. So if I could give Menistar to a 90-year-old, I guess, I don't know, about 100-year-olds. I haven't had to do that yet. But I honestly think you can't get in trouble with Menistar. It's a 14 picogram per ml dose in the average weight person. And, you know, we said physiologic dose was 80. But I like to say the target range is 40 to 80 or 40 to 60. You can lower it if you want to after age 70. But it also, I think, critically depends on the health of the individual. So I had a patient walk in my office one day. She was sent by her other OBGYN to talk to me. He wanted her to take estrogen. And she was smoking 3 packs of cigarettes a day. So I said, "You want to talk about smoking cessation?" "No." I said, "Is there any hope that you would even consider cutting down?" She goes, "Absolutely not. I love my cigarettes." I said, "I don't think we really need to have to talk about estrogen." I can't, with estrogen, undo any of that negative. So if they're really not in good health and they're not taking care of themselves, I don't think it's fair to expect estradiol to rescue you from your other bad behaviors. So when we used to say there's a healthy user bias, there is. The healthier you are, the more your tissues will respond. I tried to kind of build that concept by showing that cortisol actually interferes with estradiol action. But you can imagine if you've got a hemoglobin A1C of 9%, you're not going to get the same benefits as well. And we actually have a study going on about that. So yes, estradiol works best in those who are healthiest. I didn't hear that. But I see someone in the back standing up too.
Ovarian cancer history, like you've got a familial thing, but it's BRCA negative, say.
I mean, we don't have any data to suggest that you can't use estradiol in that context, and people have tried to study it, and it's a lot of really confusing information. So I don't want to say that we know. And I think you do have to do the risk-benefit, you know, like, but if you think they're going to survive or they have survived a certain disease-free interval, pick your one that you want, like 5 years, and now they're not on estrogen and they don't have any hormones, I mean, they're going to age faster, and so they're going to get diseases of senescence if they don't get something else.
Well, and
So.
there's a lot to be said for quality of life, so.
Absolutely. Yes, sir, in the back.
What percent of your patients are on a progestin as well?
All the ones that have a uterus? I'm sorry, that was a little... But, I mean, I try to talk people into a progestin IUD because I think that's the best bet, because that's the lowest progestin level It also leads to the least amount of bleeding, and it is really not only good for the person, it's good for everybody, right? You don't have to manage all the breakthrough bleeding, which can be difficult. And I used to think that that was the primary barrier to doctors prescribing hormones, was that it caused so much breakthrough bleeding, and that is hard to manage, and it is. So, you can actually have your friendly OBGYN insert the IUD under ultrasound guidance if there's any concern, which is how I do it in my office. And I actually always, for postmenopausal women, use lidocaine. Sometimes I even use a full paracervical block. But I want it to be pain-free, and I want it to be something that they would consider doing again. If they're 50, if they're 45, it's perfect, because they still need contraception if that's what they want. And it can last till 55, and you can reevaluate. So what I say in my office is, every year you come to see me, every year I reserve the right to refresh what I'm saying based on recent information. But I've been saying pretty much the same thing for 20 years, which is that I really think the best bet is low-dose transdermal estradiol. And I would say, this is a guess, but lower the dose by decade. But you don't have to lower it to nothing. It just needs to get a little bit lower as people get a little bit older. I wish I had a better answer than that, but the studies literally haven't been done. But I do test the estradiol level in everybody at least once to make sure that it's in the right place. Because I think you would never give thyroid without doing that. You would never manage diabetes without testing. I just feel like we have at least the right to test estradiol levels in those that we're giving it to, making sure they're absorbing it, making sure they're in the right range, making sure it's safe. And I think if you do it that way, you've done your job of trying to make it as safe as humanly possible, and people can make an informed decision with you. So that's what I do in my office. I'm not the one making the decision unilaterally in most cases. I would like the patient to be in the driver's seat as much as possible. Yes, sir.
What's the best way to test is there a certain time of day to draw it, or some time with the patch to
Yeah.
draw the level?
So the better patches, and so there's a range of patches, and some are not so good and some are better than others, give pretty much constant estradiol levels for a week, and it's in the PDR, that old-fashioned thing that we used to look up. But you can look at which ones give constant levels. The one I tend to prefer is the first one to market, which was called Climera. I assume that's a takeoff on the word climateric, but it's the one made by the Post-it note people, 3M. And it gives pretty constant levels from day 2 through day 6, so I measure it in there. Usually I just say aim for day 3, and it doesn't have to be time of day dependent, and then I want it to be at least above 40 and below 100. And if I get that and they're happy, I'm happy, and I feel like we've done our job. Thank you for that question. Yes, in the back. The estrogen in question was Premarin, and I'm trying to build the thought, the concept, that not all estrogens are the same, and that if it's given physiologically, it may not have the same impact as giving a non-physiologic estrogen by an oral route in a one-size-fits-all. So I don't think those data actually are the ones that are most compelling to me. And some of it's based on some of what I showed you tonight, and some of it's based on just knowing that if you give conjugated equine estrogens or some others, what I call xenoestrogen, you're not going to have the same impact on tissues, and it may actually have less positive effects or even negative effects.
So is that your same argument for initiating estrogen after greater than 10 years or no estrogen therapy?
Yeah, so we sometimes talk in my world for infertility about step up or step down. The longer the hiatus, the more I want to start low and step up. So I would start with a very, very low dose and see how the person tolerated it. And again, the healthier they are, the safer it is. So I always encourage all those lifestyle changes at the same time. It's not fair to put all the weight onto estradiol. It really works best if the person is engaged in full self-care. Yes, sir.
Instead of the patches, could you sub-Q long-duration pellets? Do you have any feelings about that?
So if you look at the levels, they go way up really fast and then they come down, and they actually are like most drugs of addiction. It's that withdrawal phase that drives people nuts. And they come in, and all of my early career in Southern California was trying to rescue people from that withdrawal syndrome that comes at the end of that. So I am terrified of pellets because I thought I have PTSD from these people. They're so out of control. Like, how am I going to handle this if this is the rest of my life? So yeah, with estradiol in a patch, you don't get that. You get like a constant level. If they could invent a pellet that was like time released and led to constant levels, maybe we could talk about it, but not the way they have it now. And same for injections.
So you've done some studies to look at levels. We've done levels, they look pretty good, but we haven't done them every week or every week. We've done them to start and stop there.
Look at even femring, it's supposed to be 3 months. Look at the last 3 weeks. Scary. And patients come in and they're like, it's not working anymore. You're like, well, there's no estradiol in your circulation. So it's not going to work if it's not still releasing. The stuff I told you about the progestin IUD actually has been verified for 8 years to have levels almost the same as year 2. So, we should demand data. It has to be data-driven, right? When we make a recommendation, and we have to start with pharmacokinetics. That's really critical. Thank you so much. I appreciate the question. It's always fun.